So birds are there was a second wave. Now
Yeah.
it is, I think it is settling. It is reducing.
Okay. Okay.
One week back, it was rising.
Yeah.
And again, in the initial days, many doctors was affected.
Yes.
We lost many doctors.
I know.
And in between the time, that less doctor was affected. But last week,
Hmm.
there are 7, 10 doctors again infected.
Okay. Okay. Okay.
Times
But
are coming on.
in Bangladesh, virulence of
Hello.
COVID-19 is less.
Yes. It seems so.
Virulence is probably less because
Or maybe people have cross immunity for other infections which they normally.
Yes, sir.
yes, possible.
It is a possibility.
Possibility.
Hmm. Surely. So do we start at 8:30? No.
Yes.
Yes, sir. At
Your time, Indian time 8:30, but in our time it is 9.
9 o'clock. Okay,
ফজলু
then
আমার মনে হয় স্টার্ট করতে করে দেন
জি আমরা স্টার্ট করে দেব স্যার
হ্যাঁ হ্যাঁ please.
এই পার্থ
very good evening. You all are welcome to our 2 days webinar, ABC of joint replacement. And today's our topic is total hip replacement in Protrusion acetabuli. And our renowned panel of experts are Dr. Murtuza Khair Abul Qayyum Choudhury. He is Professor of Orthopedic Surgery and Director General of Bardem General Hospital and Bardem Group as a whole. He is a renowned replacement surgeon. He was country chair of AO Trauma Bangladesh. At present, he is governor of American Society of Surgeons Bangladesh chapter. Our next panel of experts is Dr. Raju Vesh. He is Professor of Orthopedics and Joint Replacement Surgery. At present, he is working as Senior Consultant at Delhi Apollo Hospital. He is also Editor-in-Chief of Journal of Clinical Orthopedics and Trauma and Journal of Arthroscopy and Sports Medicine. At present, he is President, Arthritis Care Foundation, India, and he is first President of Indian Cartilage Society. Our another panel of experts, Dr. S.M. Amir Hossain. He is Associate Professor and Head of Department of Orthopedic Surgery at Shahid Sarwardi Medical College and Hospital. and he is one of the pioneers of joint replacement in Bangladesh. Our today's speaker is Professor Mohammad Hassan Masood. He is professor and head of the Department of Orthopedic Surgery of Sir Salimullah Medical College and Midford Hospital. And Professor Hassan Masood, he is now the leading and emerging joint replacement surgeon of second generation of Bangladesh. And he is doing good in his field. And I am Dr. Mohammad Fazlullah Kashem, working at Department of Orthopedics at Dhaka Medical College as an assistant professor. I'll be with you today as a moderator. Before starting, I like to request all the participants, you please put your questions in the chat box, then we will discuss about this. The mission of this arranging webinar, it is a series of webinar. Today is the 9th webinar after we started. And our mission is to properly educate the orthopedic surgeon who are involving in the joint replacement and thus improve the skill of surgery and reduce the complications related to the joint replacement. And now let us join today's webinar. Now may I request Professor Hassan Masood to present his topic. Professor Hassan Masood, please.
Yes. Thank you, Dr. Fazlullah Kashem. Am I visible and audible?
Yes, you are audible, clear and loud.
Okay, thank you. So, Assalamu alaikum and a very good evening to honorable panel of experts and honorable audiences. Today, I'll be talking on total hip replacement in Protrusion acetabuli. And what are the learning objectives? To illustrate how Protrusion differs from normal total hip replacement and to emphasize the importance of restoration of the center of rotation of the hip and to describe the basic principles of surgical reconstruction in Protrusion deformity. And now, acetabular protrusion is a condition where the femoral head migrates medially. Protrusion can be measured by use of Collar's line and the center edge angle of Weber. See here, this is the collar line. That means ilioischial line, and head and acetabulum protrude between the beyond this. And also there is another angle which is called center edge angle of Weber, and this is this. So if the angle is more than 36 degree or in some books 40 degree, it is protrusion. And if the head or acetabulum roof of the medial wall of the acetabulum pass to Collar's lines, it is called protrusion acetabuli. And the condition can either be a primary idiopathic condition or a secondary condition associated with a variety of inflammatory, metabolic, and post-traumatic conditions. The primary or idiopathic form of acetabular protrusion was described by Otto in 1824 and has been referred to as autopelvis. Idiopathic protrusion is an uncommon entity which is frequently bilateral, familial, more common in females, and progressive. See here, the protrusion occurs here in a hemiarthroplasty patient. See the acetabulum and the head, femoral head component protrudes beyond the Collar's line. And among patients with inflammatory arthropathy, 35% to 40% will have hip joint involvement by the inflammatory condition, and approximately 40% to 20% will demonstrate medial migration of the acetabulum as a consequence. And medial and superior migration of the acetabulum in inflammatory arthropathy is progressive, just like in rheumatoid arthritis, at the rate of approximately 2 millimeter per year. And these are the huge list of protrusion causes. I would not go to the details. I would only touch the more important things. So now, the etiopathology. It is important to consider all etiologic possibilities before evaluating treatment options. There are a number of theories regarding the etiology of primary protrusion acetabuli. Eppinger postulated that the condition was secondary to a chondrodystrophy, wherein the 3 plates of the triradiate cartilage remained unfused, allowing protrusion of the femoral head medially into the pelvis. And Alexander observed that an inward bulge of the acetabulum was normal in children between the ages of 4 and 8 years and favored the theory of Eppinger. He stated that the protrusion is reversible, diminishing stresses after the age of 8 years, permitting corrections in the majority of the children. He believed that protrusion in the adult is the result of failure of this normal correction. And this is the classification by Sotelo Garza and Charnley. This is used as the ischial line on an epiradiograph of the pelvis, and what is the what is the acetabular medial wall, how much is passed beyond this collar line. And grade 0 is no protrusion, grade 1 is 1 to 5 millimeter protrusion, grade 2 is moderate 6 to 15 millimeter, and 3 the severe more than 15. And there is also a modification. And now the history and physical examination. Patients with protrusion acetabuli typically present with complaints of activity-related pain in the groin region as well as stiffness. Occasionally, the presenting complaint is knee pain. Arising from a seated position is a frequent cause of exacerbation. There is often a decrease in the both active and passive range of hip motion, especially in abduction. Pain may occur with active straight leg raise or at extremes of motion. There may be a positive Trendelenburg sign secondary to shortened lever arm of the mechanically disadvantaged abductors. With ambulation, there may be an antalgic gait or a Trendelenburg gait or both. So sometimes patient present with significant restriction of range of motion of the hip due to neck and trochanteric impingement in the deep acetabular socket and pain associated with secondary osteoarthritis. See here, the trochanter is impinging supraacetabular area. And now, rating of the protrusion. Several methods were proposed to rate protrusion acetabuli, all of them based on radiographic studies. Some of these, the simplest, are adequate for identifying protrusion, but not to grade it, as the teardrop signal is changed, the Weiber's angle I mentioned before, and also the broken Shenton arch or line. And the most accepted and diffused is the one by Ranawat, and it is the Ranawat triangle. 2 parallel horizontal lines at the level of ischial tuberosities and iliac crests, connected by a perpendicular line passed beyond 5 millimeter of the intersection of the Shenton's line and Collar's line. And the second point, the second point, 1/5 mark the 1/5 of the total length, and from here another perpendicular line. So this triangle is called Ranawat triangles, and it tells about the original position of the acetabulum. See here, the Ranawat triangle. This is the original position of the acetabulum. So you have to restore the center of the rotation of hip here. So principles of acetabular reconstruction. Restore the center of rotation of the hip joint, manage bone loss, achieve rigid initial fixation of components against host bone, attain a stable joint, and avoid component impingement. So now come about the templating on pre-op X-ray. Optimal acetabular implant size and final position of component that restores the hip center of rotation to the normal position. These patients often have varus-oriented femoral legs and the femur needs to be carefully templated. Here is the method of templating. And now come about the treatment. First of all, conservative treatment. Patients with protrusive acetabular may initially be treated conservatively to manage various symptoms. This may include activity modification, weight loss, and physical therapy for hip flexor, hip abductor, lumbar spine, and abdominal strengthening. And now come to the surgery and what the literature says. The surgical tools employed in acetabular reconstruction for protrusion have changed with the evolution from cemented to cementless acetabular components. The diverse techniques described in the literature include the use of support rings, bulk autogenous graft with a cemented socket, morcellized graft with a cemented socket, either with or without supporting metallic mesh, cement augmentation without bone graft, medial bone graft, and a bipolar socket, and a fixed cementless socket with a medial bone graft. Among the first descriptions of surgical treatment of primary protrusion was that from Sotelo, Garza, and Charlie, reporting on the low friction techniques in 1978 and comparing the use of a cemented socket with or without slices of autogenous femoral head bone graft placed medially. The authors concluded that there was no difference in the results whether a bone graft or cement alone had been used. This report was in contrast to other reports, leading to the conclusion that component loosening may be accelerated when cement fixation is used without bone graft and the hip center is not corrected. In addition, JST has reported that patients with defects through the central acetabular wall had an unacceptably high rate of acetabular component loosening when mesh alone was used without bone graft. If a cemented socket is chosen, a flanged cup can make appropriate placement of the relatively small cup into the larger cement mantle. And the use of a supporting mesh in conjunction with medial bone graft and a cemented socket for treatment of painful protrusion was reported by McCollum. And these additional reports on the use of medial bone graft in reconstruction of the acetabular protrusion has led to general consensus that bone grafting is more likely to arrest the progression of the medial migration than acetabular reconstruction without the use of bone graft when implanting any type of fixed socket, support mesh, or acetabular ring. And Ranawat and Jan's report on 23 patients, 27 hips, treated with a medial bone graft and a cemented socket and followed for a mean of 3.5 years. None of the hips showed further protrusion, but 11% of the patients saw cement bone demarcation in their acetabular zones. The authors concluded that for protrusive acetabuli of greater than 5 mm, autogenous bone graft was successful in providing good hip function. No mesh or accessory means of containing cement was used or felt to be necessary. So now about the operative treatment. Generally, the recommended surgical treatment for protrusive acetabuli is total hip replacement. However, if the disease is unilateral in a patient who is young or manual labor, arthrodesis may be considered as a treatment option. And recent reports have suggested that symptomatic bilateral protrusive acetabuli may be feasibly treated with subtotal acetabuloplasty, femoroplasty, and circumferential labral surgery through arthroscopic means. But further evaluation of these interventions is necessary. So the treatment principles. The center of rotation of the hip joint should be restored from its abnormal medial position to a more normal position when protrusion is encountered in primary acetabular reconstruction. Dorr and Ranawat emphasize that normalization of the hip center had implications on the long-term fixation of the implant. Cortical bone stresses on the medial part of the pelvic wall increase with medial placement of the acetabular component. See here on the right hip, the patient had medial placement of the socket supported by cement, but no bone graft. So ultimately failure. And now come about the surgical challenges. Protrusion acetabular has many unique surgical challenges during primary and revision total hip replacement. The surgical approach to the hip should be carefully evaluated based on surgeon preference and degree of deformity. The sciatic nerve is much closer to the femur, and the surgical exposure, especially if a posterior approach is selected. The satisfactory capsular release must be performed around the acetabular rim and proximal femur to enhance hip range of motion and the opportunity for safe dislocation. Forceful maneuvers may result in femoral fracture and should be done with appropriate visualization and careful application of traction forces. And occasionally, the dislocation of the hip is often a challenge in primary THA. And always attempt dislocation of the hip. If you cannot do it, then do osteotomy. And subluxation by lateral traction, remove the marginal osteophytes, and circumcision of the capsule. That means 360-degree capsulotomy. And don't do in situ osteotomy straight away. And these surgical challenges, if dislocation is difficult, and in situ femoral neck osteotomy may be performed. Prior to in situ femoral neck osteotomy, retractors should be inserted protecting the surrounding tissues, and a napkin ring type of osteotomy can be performed with parallel neck cuts and removal of a central portion of the femoral neck. See here, this is a parallel neck cut and a napkin ring osteotomy. And the femoral head can then be removed with threaded Steinman pin, corkscrew, or via acetabular reamers. In severe cases of ankylosis or severe acetabular protrusion in revision THA, a trochanteric osteotomy may prove helpful for increased exposure. See here, a trochanteric osteotomy was done. It is a 3 months follow-up and 2 years follow-up. And now, the medial wall of the acetabulum usually is thin or may be partly membranous, and it should not be penetrated. I must repeat, it should not be penetrated. Medial rimming is unnecessary. Instead, the cartilage and the soft tissues are removed with a curette. The smooth sclerotic floor is roughened with a curette or chisel, but penetrating into the pelvis is avoided. So here, see, the cartilage covering the thin medial wall needs to be carefully removed without disruption of the medial acetabular wall because it is very thin. And the migration of the femoral head in progressive protrusion is generally both medial and superior rather than directly medial. Sometimes it is directly medial, but mostly it is medial and superior, making the socket oblong in shape as the femoral head progresses into the defect. See, this is the polar line. So the oblong shape will require careful rimming to create convergence of the acetabular rim without preferentially rimming the superior rim and causing an iatrogenic superior segmental defect or high hip center. If you rim superiorly, then there will be bone loss from the superior part and there will be high hip center. So how we insert the acetabular component for the protrusion. Peripheries of the acetabular walls are divergent and hip center is displaced, see, superiorly and medially. So peripheral rimming creates new rim with convergent walls, and implanted component is stable on prepared rim. See, previous center of rotation of hip and new center of rotation of hip. So the acetabulum is carefully rimmed with the goal of obtaining stable peripheral rim support of a cementless socket and at least 50% contact of the implant on good quality host bone. When good rim support of the femur is obtained, a trial component is placed and intraoperative X-ray obtained to confirm feet position and restoration of the hip COI. And now, principles of bone grafting. And there is Ranawat recommendations. When protrusion is less than 5 millimeter and medial wall is strong, bone graft is not indicated. In protrusion greater than 5 millimeter with a thin but intact medial wall, autogenous bone graft is indicated. And a grossly deficient medial wall requires reconstruction with bone graft and additional fixation devices. And now, depending on protrusion severity, morcellized bone graft may be inserted after initial acetabular preparation and medial to the acetabular component. The graft is placed into the depth of the acetabular cavity and a smaller 2 to 4 millimeter hemispherical reamer utilized on reverse. This will adequately disperse and impact the graft into the depth of the acetabulum. See here, the reaming is doing in reverse condition. And satisfactory host bone should be exposed on the native acetabular rim to allow direct fixation of the uncemented acetabular component to the pelvis. And now come about the cup positioning. The cup is impacted into the prepared socket, obtaining fixation on the rim. Cups with adjuvant fixation, such as fins or pegs, may aid in initial press fit stability. Supplemental screw fixation should be utilized for additional initial cup support in cases of significant bone grafting. The acetabular liner is then inserted for the desired femoral head side, and the femur is prepared in the standard manner for the desired femoral implant. The implant considerations, the main goal is to select the most stable construct to avoid progressive postoperative medialization of the acetabular component. A porous acetabular cup that allows for bony interdigitation with various options for screw fixation is most desirable. Reconstructive cage to gain fixation to the pelvis above and below the acetabulum, and femoral stems with an enhanced offset. So about the femur and leg length consideration, as the acetabulum is brought to a more inferior and lateral position, the femoral side is lengthened because of the prior varus deformity of the femoral neck. So a low level femoral neck resection coupled with the femoral component with the enhanced offset to be helpful in minimizing limb lengthening while maintaining adequate joint stability. So what is the postoperative management? Weight bearing is usually restricted to touchdown for 6 weeks, followed by partial 50% weight bearing for another 6 weeks. It is important to remember that these guidelines are generally dependent on the quality of acetabular fixation achieved with final cup placement and full weight bearing 6 months post-op. Now see here, this is a case, male 35 years old, bilateral protrusion acetabuli. So here cemented, uncemented hip was done with restoration of the center of femoral head. This is the protrusion both sides. And another case, another female with 28 years, see the protrusion, and it was also reconstructed with uncemented both sides. And Habibullah, another patient, 41 years, done in 2010. After 4 years, though there is some protrusion of semen, but it's still, and this is follow-up after 7 years. And see, this is a follow-up after 7 years. Okay. So the take-home message: the hip center must be placed in an anatomical location to restore proper joint biomechanics. The intact peripheral rim of the acetabulum should be used to support the acetabular component, and the remaining cavitary and segmental defects in the medial wall must be reconstructed, preferably with bone grafting. Thank you very much.
Thank you, Professor Hassan Masood, for your brilliant presentation. Now the floor is open for discussion. Now the question from Lieutenant Colonel Abdul Kader. Why protrusive acetabuli occur in rheumatoid arthritis, ankylosing spondylitis, and Paget's disease? Professor Murtuza Qayyum Chaudhary, sir, would you please? Murtuza Qayyum Chaudhary, sir, please.
Okay, okay. You muted me. I was not able to talk. Anyway, thank you, Dr. Fazlu. Can you please repeat the question?
Sir, question is why protrusive acetabuli is occur in rheumatoid arthritis, ankylosing spondylitis, and Paget's disease?
You see, in ankylosing spondylitis and rheumatoid arthritis, these are the disease, inflammatory disease of the synovium initially, and then ultimately bone get involved. So that synovial involvement, inflammatory changes soften the cartilage and ultimately the neovascularization, all destroyed these inner layers, and ultimately it happens. So this is the pathogenesis and pathology of the rheumatoid arthritis and ankylosing spondylitis. But in Paget's, you know, in Paget's, it is really, it is a soft bone due to Paget disease. We don't face any Paget. And that's why I think this softening, Professor Bushra can add something to it. Paget's, I don't have any experience on Paget's. But rheumatoid and other things, you know, particularly females, this softening and the inflammatory changes in the synovium, and then ultimately to the joint itself, reducing the joint space and other things. The same pathogenesis of rheumatoid arthritis and ankylosing, this same thing happened. Initially osteomalacia acetabuli, and then ultimately protrusion, and very, very gradual. That's why an inner thin layer remains, because it is very, very slow process, and the thin layer actually remains in the middle in rheumatoid arthritis.
Professor Rajuvesh, sir, would you please supplement?
I think all these conditions and some others as well make the medial wall weak and porous. It is soft, and hence with constant pressure of the femoral head onto the weak medial wall usually gives way. The superior part of the acetabulum, as you know, is a weight-bearing part, and it doesn't give way so easily compared to the central wall, and hence the head has the natural tendency to sublux medially and cause protrusion acetabuli.
Thank you, sir. Next question, also from Lieutenant Colonel Abdul Kader. What are the problems we may face in protrusive acetabuli during total hip arthroplasty? Professor Rajuvesh, sir, would you please explain, and including the tips and tricks, how we can overcome the problem and challenges of surgery in protrusive acetabuli? Sir, you please unmute yourself, please.
Yes, I have done now.
Yes.
Professor Masood has done an excellent presentation, has actually pointed out everything very clearly. So there is nothing much to add, but just to re-emphasize, the center of rotation has to be brought laterally so that it is in the center of the hip. you have to rely your fixation on the peripheral edge of the acetabulum, so that should not be destroyed unnecessarily. And the medial wall, the medial gap that is created while you bring the head out, should be replaced with adequate bone graft. And in these cases, especially in young patients, uh, an uncemented cup with a morselized bone graft from the femoral head, if reamed with a reverse reamer, gives you an impaction bone grafting, and these patients do very well. I partly differ from Dr. Masood, who said that weight bearing should be avoided for 6 months. It is not necessary. If you have a tight impaction bone grafting on the medial wall, and if you have a good fixation of the uncemented cup, patients can weight bear, because the most of the weight actually does not go through the bone grafted position. Dislocation can be challenging, as has already been pointed out. If you, even after good capsulectomy, if you are unable to dislocate the head, or if the protrusion is very severe from the very beginning, you should be ready to osteotomize the neck as planned earlier on the X-ray, and then remove the head piecemeal or in one position, in one go, if possible, and then proceed for surgery.
Thank you, sir. Now, next question also from Colonel Abdul Kader. Cemented or uncemented total hip arthroplasty, which one you prefer in protrusio acetabuli? Dr. S.M. Amir Hussain, sir, please.
Thank you, Dr. Kader. And also thank you, Dr. Professor Masood, for his brilliant deliberation. Professor Masood already said that this is uncemented is better one than the cemented one in case of protrusio acetabuli. And in case of uncemented, we can put morselized bone graft, already discussed, and bigger cup can use. Occasionally we can augment the acetabulum by mesh or by others implant and cup also. So uncemented is better than cemented one in case of protrusio acetabuli.
Anyone differ from this statement of Dr. S.M. Amir Hussain among the panelists, or all are agreed with Dr. S.M. Amir Hussain? Then all are agreed.
Raju Varsho.
Then probably Rajesh also agree with him. Probably Rajesh also agree with him.
Now, one thing I should add here, that it depends on the position of the, how much the defect is. If the defect is very big one, and this uncemented cup is not possible, particularly even with the bone, even with this bone graft, or even with other things, considering all the factors, if necessary, we can, if cemented is good one, more stable one, that should be considered also. So not only that, the cemented, uncemented is better, uncemented well, but if there is no other way option, then you can go for cemented. Yeah, thank you.
Then another question from Dr. Pinku. Would you please tell about the Ranawat triangle again? Professor Hassan Masood, sir, please, about the Ranawat triangle.
So, okay, thank you, Dr. Pinkushan, for your question. So, we draw two parallel line. One line through the touching the ischial tuberosities, and another parallel line touching through the iliac crest. And these lines are connected by a perpendicular line. These two lines, Dr. Fadullah Qasim, should I share the screen, or I will tell?
Okay, if you think that it will be better to explain by sharing the screen, you can share it.
Okay, okay, I can share.
Our main objective is to make the participant clear about your talk, about the
Okay.
subject.
Slide number 3.
Yes, okay.
Slide number 3.
Okay. Yes. See here, these are the two parallel lines. One is tangential to the iliac crest, another is tangential to the ischial tuberosity. Then a perpendicular line is drawn to these lines, and where through which point this perpendicular line goes. It is the intersection between the Shenton's line. You know very well, this is the Shenton's line, and this is the Koehler line. So Koehler lines and Shenton's line intersection from that point 5 millimeter medially and 5 millimeter laterally, and this is the perpendicular line, and take from this point 1/5 of the perpendicular line. So from here to here, and draw a isosceles triangle. From this point, draw a perpendicular line, and this is the margin of the acetabulum, and draw another line. So it is the triangle. It is called the Ranawat triangle, and so it depicts the original position of the acetabulum as is shown in the next picture. See here, this is the Ranawat triangle.
What is the significance of this triangle?
Because during templating, we cannot ensure the position of the acetabulum. See here, we can think this is the false acetabulum, but we can think that this is the original acetabulum, but it is not the original acetabulum. Original acetabulum is here. So for this tracking the original acetabulum and to make the center of rotation clearly, we make this Ranawat triangle. I think Professor Raju will add some point.
Rajesh sir, would you please? Sir, unmute yourself, sir. You are muted. Rajesh sir, please unmute yourself.
Dr. Masood.
Yes, sir.
Yes.
এখানে নিচের দিকে, do you think that the teardrop is the basic line? Teardrop.
Yes, sir. Yes, sir. Another point is teardrop. I mentioned, sir. And
mentioned it.
Yes, sir.
So the teardrop, the vertical line goes up.
Yes, sir.
I mean, from the ischial line to the the iliac line.
This,
right?
yes, actually, these 2 points. One is tangential to the ischial tuberosity, and another is tangential to the iliac crest, then a perpendicular line. And also, you during your marking the triangle, you must see about the teardrop, because this is the lowest point.
Okay. And the other line, the upper one, how the upper one was met? The upper line.
This one, sir?
No. The transverse line, the horizontal line.
Okay. Yes, sir. I am just this line.
Yeah. That's right.
Okay, sir. This is a intersection point of Shenton's line and this Koehler line, and from this intersection we go 5 millimeter laterally and take a point. From here we take 1/5 of this length. This is the total length, this perpendicular line, and we take 1/5. So from here to here, it is 1/5 of this total line. We make a point here and take another perpendicular line from the superior part of the acetabulum.
Outer edge of the acetabulum.
Yes, outer edge of the acetabulum. It may coincide or not coincide actually, but this point is 1/5 from here, 1/5 of the total perpendicular line. We put a point and then a perpendicular line here. So it is the Ranawat triangle, sir.
Okay. Fine.
Professor Rajesh sir, would you please supplement?
Yeah.
The Ranawat triangle and its significance?
I think Ranawat triangle is more of a theoretical value than of practical value, uh, because it is very, very difficult to actually be symmetrical all the time. You have different types of AP pelvis X-rays with different angles, uh, different orientation, so you may be inaccurate. The simplest and the best way is to use a Kohler line and a teardrop. Uh, this is more of theoretical importance and I don't rely on it.
I agree with Professor Raju Bosho.
Welcome, sir.
Yes, how are you, sir?
Very good. So far, so good.
Yeah, good, 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 good. Thank you so much for joining. Yeah.
Thank you.
Okay, I do believe that Ranawat city, it is not being practiced, I think, by many of
I
the
think one of his fellow might have, got this idea and got it published. Ranawat may not be using it himself.
who is the fellow, that fellow? Maybe Raju Bosho.
It is Professor Hassan Masood. Anyway, sir,
Okay.
we, let us advance
But
it.
can I just add one more thing here, which was not discussed? There is now availability of trabecular metal, which is very good for bone ingrowth. And if patient is affording trabecular metal cup, is very useful. And now trabecular augments are also available.
Yes.
Suppose if you have a revision total hip replacement with protrusion, where you don't have bone graft available, autograft or allograft, then trabecular metal augments, and trabecular metal is a wonderful thing. But they are expensive.
There are Zambu cups or some cups are available now.
Yeah, jumbo cups, bilobed cups are
Yes.
available, but
Yes.
they have to be arranged. The largest size jumbo cup is 66. So in complex cases, if the acetabulum is quite severely deformed,
Yes.
sometimes that also is not sufficient. And in that case, you should not be hesitant to use a cage to rely on your fixation.
Mm.
Although the results of using total hip replacement with cage are not as good as doing a primary total hip replacement, but it's a salvage procedure and you have to do it.
It is available in India, not in Bangladesh.
Yes. Yeah, it is available in India now.
And we need to procure from
Yeah,
the
sure.
company. Yeah, that's right. Okay.
Okay, sir, Rajiv sir, would you please compare and discuss between this the mesh and bone graft and octopus cup and what you were saying about this latest thing? Which
Yeah.
one is good and which one in which place is applicable?
See, it is very simple. If you have a very mild protrusion, less than 5 mm, you don't require any grafting or special fixation. If the defect or the severity of protrusion is more, and the acetabulum is not uniformly contained, if it is very bizarre and large, then you have to use some metal with bone cement or bone graft to augment it. And in that case, simple mesh, uh, Striker has very beautiful mesh that can be used and fixed with few screws. If you need more strength, then and if the cavity is large, you need to go for some sort of cage like Burr Schneider cage or octopus cage like things. But as I said, do not try not to use cages because the results are not good. But if you have no other solution left, and if the cavity is very large, you have to use that.
Thank you, sir. Professor Murtuza Kayum Chaudhary, sir, in presentation of Professor Hassan Masood, he said, during the options of treatment of protrusion acetabuli, in unilateral cases, sometimes arthrodesis may be done. Do you agree with him? Instead of doing total hip replacement in unilateral protrusion acetabuli, will you advise the arthrodesis of the hip joint, or you will advise for the total hip replacement?
Okay, Dr. Hassan Masood covered almost everything, but this matter of this debate will continue because nobody can say anything. A case to case varies. But in general, arthrodesis is discouraged nowadays. In 2020, arthrodesis nobody will prefer. Arthrodesis may not be an option because we have a lot of ornamental and models and accessories of the, you see the trabecular metal, he said, and other things. These things give us an option to make something. So arthrodesis is nowadays really, I don't feel there is an answer. And the basic thing we are not mentioning here, number one, a surgeon with good experience on total hip replacement should go for protrusion case. It should not be his first case. If it is first case, he must keep a good assistant or a good colleague with him. Number one. Number two, the cutting the neck and dislocating it in pieces is possible when you are doing a primary protrusion. But when after a hemiarthroplasty or a total revision, you are doing it, because I seen a case, she is a very renowned lady in Bangladesh. I'm not revealing. This is done in Bangkok, the total hip replacement uncemented, and there was no screw in the acetabular metal cup, and it was looking like a bipolar, like something anyway, but it was really the total, because without a screw you cannot, many people just understand it is total or bipolar anyway. And absence of that is two screws may be one of the factor of going gradually, and total metal cup with the implant all gone inside the, really totally gone inside. And this happened how, I don't know, about 10 years about, and her condition was not good at that time. She was actually a case of SLE, that was the factor. So we are not able, being a wife of a renowned professor of medical science and mother of a doctor, we are not able to do anything. And ultimately she died from other problems. But in a total hip with uncemented and metal back, it gone in is one case I seen it. So when, if we don't, we don't mention this, when it is a cemented thing already done, you are doing a revision, it should be considered as a revision. And trochanteric osteotomy is a good option. And unless you have a very good ultrasonic devices of removing cement and other things, I prefer long sliding trochanteric osteotomy. That helps in reducing the cemented stem and also becomes easy. If you try first on anteriorly or posteriorly, no problem, and then fail and then do a trochanteric osteotomy, it is rather go for the, so preoperative decision is most important. In an advanced case with cemented prosthesis in situ, you go for a trochanteric osteotomy, primarily sliding osteotomy, so that you remove it. And Dr. Hassan Masood was also getting one question during our rehearsal, that how to remove the cement and the break and the other things are complicated, Professor. Amjad also said this removal of the cementing is very dead. What I do in this thing, I made when it is not long stem, I made a opening window 2 centimeter or 3 centimeter below the lower end of the femoral stem, and through that I hammer it out from the apex, and that hole is very good. It should be a bit oblique, and you should have a punch, and that punch and hammering it goes out after reduction, of course. So reduction is a must. If you cannot remove it, cement should be removed with a sliding, long sliding state, and you can easily fix it with 2, 3, 4 circlage wires. So I must say again, this needs a lot of experience. Experienced surgeons do this thing in advanced cases, and breaking the stem and doing some abnormal and unusual things, and ultimately even failure of removal of the head from the pelvis is happened. I don't know. I never done any failed, and I was not able to do something. But these things already reported. So my request, my friends, if you do a good number of total hip replacements, you keep in first protrusion with some expert with you, your colleague or your expert second person, and keep ready, cemented, uncemented. Surface wires are your friends, and keep almost many instruments, orthopedic instruments ready, and your drill and saw, everything will help you. So that day you should keep your time and CM use, because this you see, it is very easy to say center of the rotation gun medially and up in these things, and placing it is very difficult. And sometimes the soft tissue mobilization needs a lot of soft tissue mobilization. Otherwise, it cannot pull down, cannot bring out our instrumental. This many offset sizes are not available. We have usually stem difference and cup difference, but offset. The initial groups of Chanlis, Cobra, and other things have a lot of offset options. Nowadays, all these things are obsolete, and now came modular. So modular length, neck length, this cup size, stem size, these are modular. But offset modular is less in our country. So you need really a pre-operative assessment and keep everything ready and be ready for a good time if necessary to do such an operation. Thank you.
Thank you, sir, for your details explanation regarding the total hip replacement in protrusion acetabuli. Now, may I request Dr. S.M. Amir Hussain, would you please share your experience? You mentioned prior to start this webinar, you do the total hip replacement in lateral approach. But for the protrusion acetabuli, where you need to reconstruct the acetabulum, you go through the same approach or you choose different approach for the protrusion acetabuli. Which one do you prefer?
Thank you, Dr. Fazlur Rahman. I salute the Raju Basho as because I learned lateral approach from him at the 2006-7. At that time, he came at Nitor, and I was the Nitor working in Nitor, and he probably pioneer in lateral approach in Bangladesh. From him, I learned lateral approach. Again, in protrusion acetabuli, I think lateral approach is better than posterior approach, as because posterior approach you may injure the sciatic nerve. And, for the lateral approach, we can remove the head by more easier than posterior approach. Occasionally, we can do the osteotomy of the femoral neck, as already said by the Hassan Masood, and you can take the head by piecemeal or by corkscrew. And also already discussed that during reconstruction, we can use the bone graft and other augmentation of the by mesh or by or by case or by others or metal augmentation which is available in your hand. So lateral approach is better in protrusion acetabuli to me.
Okay.
Dr. Bozlu, may I say something here?
Yes, please, sir.
Yeah, the lateral approach is always good. Why? You are positioning in lateral positioning of the patient allow you your knee to drop anteriorly down. That gives a good facility for entering the stem. One. Number two, if you go by a lateral incision, you can go anterior. You can, if necessary, go posterior or posterior and then anterior. Both are in your hand without changing the position of the patient.
Position of the
In
patient.
posterior, you cannot go, and lateral, you cannot go anterior. In anterior, you cannot go lateral. You can go lateral, of course, but not posterior. Lateral is really a very good position, and it facilitates. And orientation in such cases of the acetabulum is good after a trochanteric osteotomy, because this is particularly when not primary protrusion, when after a initial primary or hemiarthroplasty primary, this protrusion is usually difficult. And if already there is a lateral incision and you know it is in the operation note previous anteriorly that Dr. Gahan, you go posterior. If lateral approach, go posterior. If it is posterior, you go lateral or anterior. Try to avoid that side because the scarring is too much. Lateral mobilization is better. And that weak point becoming second time another weak soft tissue is recurrence will be high of dislocation. So go to the, if possible, to a normal tissue, like spine. If in the PLID operated in the right side, you approach from the left side because that is scarring and fat graft given or not, everything is problem. So this is the same principle. Try to be on your normal anatomy and normal tissue. And then you can go to the affected side if necessary, because you know you already opened your normal structure, everything, and you know the it is, if necessary, you can go to the scar tissue. Thank you.
Professor Rajuvesh sir.
Yeah.
He may add because he is very experienced person. We want to hear from him.
So
See,
far, I can remember you do total hip replacement in anterior approach, keeping the patient supine. Am I right, or you do it in lateral, as Dr. S.M. Amir Hussain was saying?
see, the original lateral approach was first described by Harding, was done in supine position with a sandbag under the buttock. But we have now modified Harding approach where you turn the patient laterally, and that's what I use. In supine position, sometimes there is difficulty in reaming the femur if the patient is especially obese. So better to do it in lateral position, lateral approach. I do all my hips by lateral approach. I only
Yes.
use posterior approach if I have to do something posteriorly, like wall reconstruction, or if the patient had some specific issues related to the posterior wall. Otherwise, most cases, including protrusion, can be easily done from lateral approach. And as has rightly pointed out by early two speakers, you are away from the sciatic nerve, which comes very close in protrusion in the posterior approach. Secondly, you have excellent 360 degrees orientation of the acetabulum, which is so necessary to reconstruct the central defect. So my choice is lateral approach.
Thank you, sir.
Thank you.
Then Professor Partho Sarathi Soham sir has a question. Now, may I request Professor Partho Sarathi Soham sir, you please ask your question, sir. You please unmute yourself. Yes, sir. Sir, you please unmute yourself. Yes, sir.
Yes, I actually unmute. Am I audible actually?
Yes.
Yes, sir.
Now it is audible, clear,
Thank
and
you.
loud.
Yes, sir.
Professor Amjad, Assalamualaikum, Karim Bhai. Great
Ah.
man. great man with us today, actually.
No.
Very
That is
great
all right.
man. I am belongs to the same land, Sylhet actually. Very much glad to see you in a very loftiest chair in the country, actually. I don't, I actually not acquainted with a very eminent surgeons of India, Apollo Hospital, Delhi, Professor Raju Bosho. I am Partho Shardi Sham from Sylhet, remote area. That is not Dhaka, that is a remote area I am speaking actually. I like to felicitate Dr. Professor Bosho for
Thank you.
his very coming to Bangladesh and for his nice deliberation. And I am also thankful to Amir Hussain actually. I am thankful to Amir Hussain very much for his
Thank you, sir.
excellent
What is your question, sir?
yeah,
Thank you, sir.
presentation করছি আমি একটু বলতে হবে তো
জি,
না
স্যার।
বললে হবে না, আমি
জি।
শেষ করে ফেলবো প্রশ্নটা হচ্ছে এটাই
আরে,
question is like that I'm asking a very basic question actually. Basic question is that I to the all and my friend is Professor Amjad is here. He's doing his he did that work for a long time actually. I'm very proud of me actually. I am just a learner. I mean, I am telling that there's some surgical strategy standpoint before doing the surgery. That is we must adjust the medial wall of the acetabular. First, number one point. Number two is one thing is whether the protrusion is convergent or it is divergent. Second standpoint. My third standpoint, I must judge whether it is a simple or complex protrusion. Complex I mean that medial migration associated with proximal migration. And that is some problem actually. I like to make it clear from the panel of expert and other expert regarding this actually, and they should furnish their valuable opinion in this regarding. And also, I like one point. I utter one thing. There is a word in the literature, judicial lateralization of the.
Femoral head.
What is the importance of it? And I like to make me clear personally. Thank you very much.
Professor Rajesh, sir, please.
Yeah, I think very good questions. The strength of the medial wall can be judged most of the time on the X-ray if there is sclerosis or not. But when you are operating intraoperatively, I use a simple K wire to see the strength of the medial wall. So you put your K wire, if it easily goes, this means it's weak. You should not go and ream that area. Sometimes there is only a small membrane which is covering which is separating your acetabulum from the pelvis. So judging the medial wall strength is very, very important, as he said. It is also important to note if it is a divergent or convergent acetabulum, because if it is a divergent acetabulum, then you have to ream the mouth of the acetabulum with the peripheral reamer to start with, and then go slowly inside, right? So bigger reamer first, and then you slowly do that. And the last question, the last part was, what was the last part?
Center of protrusion is lateralization of center of
Yeah,
protrusion.
if you think that protrusion is a complex one associated with superior migration or posterior migration, then a pre-operative CT scan is very helpful in planning. So in most cases it is not required, but in complex cases, especially in revision situation or patients with war injuries, gunshot injuries, blast injury. We get a lot of patients from Afghanistan and Africa, and you have to do a pre-operative CT scan that gives you very clear idea. And now we also make a 3D printed model of the hip, which actually gives you excellent idea where is the defect and how you should plan before actually going into the surgery. So if you have facility for 3D printing, absolutely it should be used.
Regarding the divergent and convergent, I like to ask actually Professor Raju Bosho.
Yeah.
Regarding there is actually when you like to ream, if
Yes.
if it is getting looser, then it becomes divergent. Somebody is telling, but normally it's getting tighter. It is converging. What is your opinion?
Yeah.
Reaming during reaming, Pre-operative.
As I said, if the mouth of the acetabulum is small and the inner side is big, then you have to ream the periphery first. Don't go with a small reamer inside and then come out. So ream the periphery first and then you go slowly inside. And if you have a divergent, obviously you should not penetrate the medial wall, and it is much more easier than the other type.
What about the judicial lateralization?
Yeah, judicial lateralization means that you have to try to bring the center of the hip from medial to the center. So you have to lateralize the head so that you have good abduction arc and good abduction power, and you also restore the length. But here I must tell you or warn you that in cases of bilateral protrusion, if you are doing one side, uh, then you must tell the patient that your leg will be longer than the other side, because longer leg is very troublesome for the patient. So they must be ready to wear the extra sole on the normal, on the less affected side or non-operated side, and as soon as possible you do the other side also. This is very important.
Okay,
Thank you.
Thank you.
This lateralization, Dr. Fazlu, lateralization is very, very important. Number, the center of the hip is okay, but if your fulcrum is not tight, good enough, the dislocation may occur, dislocation, and the abductor will weak. The patient get the abductor should be good enough, tight enough, and without lesion, the good fulcrum. Only if you see the origin thought that lateralization was the most important to our hip function. Nowadays we don't see the topic, so the question of lateral much. We brought the head out and down, and the trochanter automatically goes laterally. But if you do in a short neck or something or some other cases, lateralization is most important. And if you do a trochanteric osteotomy, and if you don't place it rightly, if there is this offset length is reduced, abductors will not work. So this is an art, this length, this antiversion, and the tight of the muscles, tightening of the abductors, and no injury to the nerves and vessels, of course, no problem. And everything is a combined, and must consider the other points, the physical fitness of the patient, the age, the other comorbidity. So many things comes ultimately bring the result. And everything should be discussed with the parties or patient. Counseling is very important. And this acetabular operation should be taken as a seriously difficult operation, of course, unless it is really in a 5 millimeter or below. It is really you cannot guarantee a perfect. And as Professor Bush said, the length is troublesome and short is a bit acceptable, but too much short is also not acceptable. And patients are nowadays going to Google and reading themselves many things, experts. They're not doctors, but they are very experts. And they make you a bit during your round, so many questions and other these things. And so everything counseling is very important for a good result. Thank you.
One more small surgical tip which I have used. Sometimes the incarcerated head in the deep acetabulum you are unable to remove even after osteotomy. In that case, or in cases of severe ankylosing spondylitis where you have bony fusion or almost a bony fusion, you do reaming on the cut uh, portion of the head, which is lying in the acetabulum. You slowly ream, and ultimately you will reach to a place where you will find the head moving, and then you can remove it. So sometime you have to try and do that if in case the head is totally stuck and you are unable to remove it.
Thank you, sir.
Professor Bosho, just one thing to know. I am
Yeah,
routinely now using the tranexamic acid. Do you using it regularly?
Yeah, I use tranexamic acid in almost all cases, except those who have history of cerebrovascular accident or myocardial infarction type situation. Otherwise, all patients have 3 doses
Good.
of tranexamic acid, one in hip replacement, one pre-operatively, then one 3 hours later, and one 6 hours later.
Yeah. Thank you. Thank you. It is really beneficial.
It really, and I'm using it for last 20 years with good
Okay,
success.
I am using for last 5 years. Very beneficial. Thank you.
Thank you, sir. So far, the questions placed in the floor are discussed, and the other issues which were placed are discussed. If we do think there are no more issues that to be discussed, then we can conclude our today's webinar. Sir, do you agree, sir? Can we?
Yeah, the Fazlu, before you end, I must thank you.
No, sir. I will give you chance before conclusion that you to say the concluding talk and the take-home message. Then before that, let me confirm that we are ending it.
Yeah.
Okay, sir. Then we are ending it. Professor Amjad Hussain, sir.
Fazlul Qasim, I have a single question, very small.
Yeah.
Okay.
Yes,
Okay,
sir.
I'm asking my brother, elder brother, very beloved brother, Professor Qayyum Chaudhary.
Sir.
Yes,
Because
sir.
he has got lots of experience regarding this protrusion in rheumatoid arthritis. What is your follow-up result? Do you think your arthroplasty is long-term or it is short-term?
You see, I have not much cases of rheumatoid arthritis, as it is not much here really. But these people remain a bit depressed and with lot of aches and pains. Many are taking MTX, many are taking Selagine, many are taking some other drugs, immunomodular drugs, and the pains in the hands, knee, back, everything, muscle wasting. So they are really not gratifying to them and not gratifying to me also. That's my comment.
Can I add here?
Yes, yes.
I have a lot of experience of doing rheumatoid arthritis patient with protrusion, and the results are excellent. They are as good as, almost like a normal total hip arthroplasty, and the bone graft tend to heal very fast in these patients over a uncemented cup. And rheumatoid arthritis, on the contrary to Professor, what you said, my rheumatoid arthritis patients are very grateful compared to osteoarthritic patients who are very demanding. And even a little pain will disturb them, but rheumatoid arthritis patients, since they are so incapacitated with even a little good result, little pain relief gives them tremendous help. It's like giving one roti to a person who is very starving. He'll be happy. He doesn't want a sweet.
Really, yes.
Right, right. Very good.
It constituted 18.7% actually of the secondaries, actually, rheumatoid. Probably. 18.7%.
Now may I request Professor Raju Besh
Yes.
to give him concluding message and take home message. Then Professor Amjad Hossain will conclude.
Yes.
And before that, I want to say something about the friendship between the Raju Besh and Bangladesh. He trained many of our young surgeons in his Apollo hospital. Probably I was his first fellow doing the fellowship in May of 2005. Then after that, Khalid Musharraf, GM Reza, Major Mannan, then Kamruzzaman Tushar, also Shamirul Islam.
Late Babu.
Yes, and ATM Zulfikur Rahman, many of them are trained by him. He also attended consecutive 2 or 3 pre-Boscon workshop on joint replacement in 2006-7, what Dr. Amir Hussain mentioned. So, Dr. Raju Besh, I will request you to give this contact and connection continue whenever you get chance, and certainly we will keep in touch, and whenever we need your help, please extend your hand to help us. Now you please, your
Dr. Fazlu.
Dr. Fazlu.
Dr. Fazlu. Dr.
Sir.
Raju Boshu has been given the honorary, membership of the Bangladesh
Yes,
Orthopedic
Bangladesh
Society. Do
Orthopedic
you know?
Society, yes.
We haven't mentioned it. You should have mentioned.
Thank you. Thank you. Thank you, Dr. Fazlu, for your very kind words. I must thank Bangladesh Orthopedic Society and Bangladesh Arthroplasty Group for giving me this opportunity this evening to share my views and participate in a fantastic program today. It was beyond my expectation. And I'm so happy that the seeds which I grew almost 15 years ago are now roping beautifully, and the young boys, young brigade is now has taken over and doing a lot of good work for Bangladeshi patients. So I'm really happy for that. And I am also thankful for Bangladesh Orthopedic Society for giving me this honorary fellowship so that I keep connected with you all. And for our journal of clinical orthopedics and trauma, I am on the editorial board of many journals. Bangladesh reviewers do a lot of help to us by reviewing our papers, and I am thankful to them. I don't think there is much to be told anything extra about protrusion hip. It has been discussed very beautifully, but amongst all the defect, especially if it is a posterior-superior defect, I would love to do a central defect, which is easier to deal with and gives very gratifying result compared to the other complex defect. And it is not so difficult, but some tips which have been discussed that these may pose, one must be very, very careful about these patients. Thank you for your attention.
Thank you, sir. Then Professor Amjad Hossain will conclude the session. Before that, I want to announce that we usually arrange our webinar in every Saturday. Today's webinar, we concluding about the hip talk. Now we will go to the knee. Then before that, we'll take a pause. We are planning to arrange a discussion about the advancement of joint replacement in Bangladesh with some renowned international and regional faculties. And let we plan and complete the setting. And before that, we are taking some time. We'll announce in time. So next, we are not announce our next webinar now. We will inform you all later on. And now I request Professor Amjad Hossain sir to conclude today's webinar.
What about the presentation I have sent to Dr. Masood? He has not, as our experience, humble experience.
Sir, I can just play the PowerPoint. You just comment and
Yeah, you
deliver
do it.
something.
Yeah,
Okay.
that will be nice. I was expecting you to present some of the cases. Yeah. Okay.
Okay, sir. Here, please.
Okay.
I'm yeah. I'm just.
স্যার আসসালামু আলাইকুম আমজাদ স্যার
হ্যাঁ,
স্যার টেনাক্সিমিক অ্যাসিড কি স্যার আপনি ইউজ করেন?
করি। যখন if there is bleeding, excessive bleeding, I use it locally.
আমাদের তো স্যার আমরা কখনো লাগলো মনে হলো না এই জন্য।
Actually, ankylosing spondylitis, rheumatoid arthritis, এগুলা কিন্তু ব্লিডিং টেন্ডেন্সিটা খুব বেশি থাকে।
বেশি থাকে।
ট্রানএক্সামিক অ্যাসিড ব্যবহার করলে কিন্তু অনেক ব্লিডিংটা কমে যায় স্যার।
একটু রিস্কও থাকে সেই দিক থেকে।
Not always, but যেগুলা প্যাথোলজি থাকে, যেগুলা প্যাথোলজিক্যাল হিপ থাকে, যেমন রিউমাটয়েড, অ্যাঙ্কাইলোজিং স্পন্ডালাইটিস অথবা
ঠিক আছে
সেইগুলাতে অবশ্যই ব্যবহার করা উচিত।
এবং অনেকগুলো ক্ষেত্রে there are a lot of bleeding tendency in some patient. Suppose I remember one patient, very young chap, bilateral hip, and he was having low hemoglobin. Then pushed 4-5 bags of blood within a week. Then he started bleeding at the time of of surgery, particularly on reaming. So in that case, it helps a lot by cutting.
প্রাইমারি সার্জারি ছিল না স্যার? রিভিশন
না, রিভিশন তো আমরা খুব কম করি। It's a rare.
Dr. Follo, can you see the presentation?
হ্যাঁ, দেখা যাচ্ছে। তুমি একটু বড় করো, just enlarge it.
This sir. Okay. Sir, so please. These are the cases of you.
Enlarge করো, enlarge, make it enlarge little bit.
I enlarged only, sir. Already.
Enlarge.
এটা স্লাইড মোডে যায় নাই।
যায় নাই এখনো?
যাইতে হবে, yes.
Okay.
স্লাইড মোডে।
Dr. Raju Bosho. Hello, Raju Bosho.
স্যার চলে গেছে নাকি?
Hello, sir, Raju Bosho.
Yes, please tell me.
Oh, great man. I always remember you so much. Actually,
Moderator, I think you have to click the enable editing.
and
Dr. Fazlul Qasim.
very difficult by
Yes.
given to him
It
by
is
okay.
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 Okay. Sir, please. Professor Amjad, sir, please.
Okay. So please, this is a case of Acha. So this is a case of 18 years male. I think it is a case of rheumatoid arthritis, not been mentioned here. So it's a very young chap, sorry, 18 years, and this OT date was 26/2/2013. Defects actually this specific.
इधर कौन है? अच्छा, तू यहीं सो रही है क्या? अच्छा।
Has been made as per this. Yeah. So go for the next slide,
Yes,
please. Go for the next slide. Yeah. So migration of the head. Yeah. This is the gentleman. This operation was done in 2013. So later on the follow-up, and still he's good. Yeah. So this is a case of rheumatoid arthritis. And then another case, 92 years, and OT date was 8/7/12, is because of the implant. Hemiarthroplasty, we used to do a lot. We used to do a lot of hemiarthroplasty. So the defect below the superior dome as well as the migration of the head, but it is less than 2 centimeters. No ischial or teardrop lysis. You know, Dr. Adubasho, this is the, I mean, the classification has been made Paprosky, so this is his classification. We put it there in that way. Next slide, please. Masood.
Yes, sir.
This gentleman, yeah,
Okay.
with cemented hip. What Dr. Amir was telling that I think non-cemented is better. Yes, that is non-cemented is still better. But when you have got a big, I mean, gap and you can put the cement is good, then you go on cementing. This is an example of that gentleman running, walking, and stair climbing. Yeah, next slide, please. So another lady, this is a 65 years old man. And you see again this totally hemiarthroplasty, and then after that the hemiarthroplasty was removed, and then putting the same superior dome is not very defective. Medial migration is very less. So cementing, and next it is also cemented done. Next, please. The gentleman is walking normally. Because as you said rightly, Dr. Masood, that no, this is our learning. Don't go in the medial side. And Raju Basha also said only you can put a K wire and examine. This was our initial cases. We hadn't any idea. We hadn't have. So there was little bit reaming, and the cement was also inside, gone inside. But still, it is good because he is walking. This is a 28 years old male, rheumatoid arthritis, you know, and that is, you see this, how the flexion deformity of both. And 28 years only, the boy. So very case. Next, proximal migration as well as medial migration is there. Next slide. This bilateral total hip non-cemented, as it's said by, I mean, Amir, 5 years follow-up, the boy is running, you know. Okay, the right side is over the Harche. Right side is the click call. Yeah.
Yes, sir. Okay.
Okay, next slide. Yeah.
Yes, sir.
Right. He's running, yeah.
Yes, sir.
Unbelievable. Okay, rheumatoid arthritis.
Yes.
Next case, yeah.
Yes, sir.
This is, as you know, this is a psoriatic arthritis and vasculitis. This is a very difficult case. Protrusion of both sides, proximal migration as well as the dome as well as the medially. And so the 32 years old doctor, he's now a pediatrician in Faridpur, and really difficult. It was done in 2010. And next slide, please. This was his position. And this is his non-cemented total hip. I think Raju Basho can help us how to improve the situation. Next slide. Yeah.
Thank you.
He is now working as a pediatrician. This gentleman with white apron, white shirt is standing in front of the patient. He's a pediatrician. Okay. Next. So we are happy. Yeah. This is a female, 55 years. This is also, you see the bilateral AVN, and someone, our friend, our colleague, our student tried to put cemented hip on the left side, cemented hemi, and then it was removed also. So ultimately we had to go for, we couldn't remove, as it is told by our beloved senior, the Kayam Chaudhary, very difficult to remove the cement. So we were not able to remove all the cement, and then we put the cemented hip. But I tell you, the story is not here finished. You see, next slide, please. So this lady started walking, and 6 years after, next slide, please. This is the situation, Raju Basho, would you please see? Because after 6 years, that has happened, because that time we hadn't had, I mean, the long stem. So one learning is here. We should use this sort of cases when there is lot of, porous bone. So you should use the long stem. Otherwise, periprosthetic fracture is maybe a problem. So next slide, please. Yeah. So this is 75 years old. Again, medial wall defect, medial migration. OT date 5/6/17. And you see, this is also implant hemi. As we are doing a lot of hemi, I'm always requesting my colleague not to use cement. You see, cement is difficult to get out, and infection is also in my hand. I got a lot of infected cases of cemented hemi in the stem or femur, because not that it is contraindicated, but the problem is our environment. When we are doing it in a very, we are taking lightly, not even giving importance of the infection, that may end up with a very bad result. Next slide, please. So this is the situation. This lady is working with this long stem. We know in 1716 we got this long stem from a striker. Striker, as Raju Boshu said, this have got a mesh as well as they have got this long stem also. Next slide. So this is another case with trochanteric fracture, pathological trochanteric fracture, 27 years old male. And then it was converted to, because it is failed, and then hemi applied. So within a year, so again, 2011, 2012, this DSS then converted to hemiarthroplasty, and then again this medial migration, which is very common. Next, please. So this boy given cemented stem, but non-cemented cup. The problem is here also, because we were ready to put long stem here, but because of the DSS and all this operation, this was difficult to put the long stem, and then split it in the trochanteric and subtrochanteric region, and we had to use the wire, the circular wire, as cable is not available. Now this man is working. It is, I think still he is good, but I don't know when it will break, because it is a short stem, and there is some osteolysis is also there around very closely, if you see around this wire. Next slide, please. So this gentleman is working actually, but I don't know how long he will be working. Yeah, next slide. You can see that, yeah, Dr. Masood, you can see that around wiring, there is some lysis is there. So maybe periprosthetic fracture in that case. Long stem should have been better, yeah. Next. This is another case of 33 years, date of operation 15/9/2012. Here also you see, this is again a rheumatoid arthritis, and very much as you commonly happen, and somebody asked that, why the protrusion is there. So there is protrusion, there is lot of protrusion, there is proximal migration and whatnot. So this is a severe superior lateral migration, and then a medial migration as well, both sides. So we did non-cemented total hip. Yeah, go for. As Raju Bashu said, that it's not that bad. Next slide. So this gentleman here with total hip, yeah, as it was 3 screws were given, because we were not very happy with the, because so not a snug fitting was the cup. So we had to use 3 screws each side. Next slide, please. So this is another 60 years fall from floor, and a hemiarthroplasty done again. And this is another case, this pushed inside. On the right side, you can see Masood. The whole thing has been intruded. The whole thing, Partho Sharathi, yes, please see, please. On the right side, the hemi has been pushed inside in the pelvis. So can you see it in the pelvis? Partho Sharathi shown?
Yes.
Yes, you see here, very right side, how it was intruded inside the pelvis. Yeah.
Yes, yes.
Please. Next, please. Next slide. So at the operation theater, this is this hole, you can see this big hole in the middle, on the lower middle slide, and a lot of cement, and the implant is out. But next slide, please. We could not do anything because this is a totally posterior column broken, and so ilioischial line is totally gone, and osteolysis is there. So not possible to push anything. Still she's, waiting. If we can, and she's a poor lady, we can have, we are not available the jumbo cup as it is said by Raju Bosho. If we get it, we can go for this sort of surgery. Yeah, but they are very poor. They can't afford so much, 6 lakhs, 7 lakhs, 5 lakhs money. Next, please. The another case, again, rheumatoid arthritis, very difficult case. You see how much protrusion is there. And we had to 55 years old person. I think next slide, please. Next slide, please. Yeah, this is the lady. She's there. She's mesh is used. See, mesh is used here. Parthosaurus, you can see the mesh.
Yes.
Mesh is used on the medial side, and then
Yes.
non-cemented total hip. Yeah. Next, please. The cup is little bit vertical, not horizontal. The other side also done. Next, please. This is another very bad case. This is psoriatic arthritis of a 40 years old man with so much. You see the CT, the 3D CT, you can see how the intrusion is. The head is inside the pelvis. So you can understand that this gentleman can't walk at all, and no abduction at all. So next slide, please. This is done in 17. So this bone graft was put inside on the medial aspect of the cavity, and then the mesh, and then you see the mesh is there. You can see the mesh. Partho?
Yes, I'm saying.
Yes. You see bone graft is on the left side slide, and the mesh is on the right side. Yeah. Next slide, please. So this is the cementing is not although very good, but still he is working, he is doing everything. So even on 22nd, he has sent this video. Although he's little limping, but still he is doing good. And that was almost 7 or 8 years, yeah, running. Next, please. Another case, again, you see this so badly involved, the female 60 years. You see female is more common in protrusion. So here also severe posteromedial migration, and then you can see it. And then we had to go the non-cemented hip, and the right one is not very good, but I'm not very happy with the right one. I don't know how long it will be. In 14 it was done. Still she's working, but how long it will last, the right one, I don't know. But left one is good. There's also mesh is given here. So yeah, another case, 45 years, so bad. And then the severe ischial lysis, Pola's line also broken, 45 years, and bilateral cemented hip done. Yeah. So next, please. This is the last case. And this gentleman is still standing and walking. Yeah. 5 years follow-up, cemented. Yeah. And this is the case, 70 years. Again, very badly, protrusion. So severe superior medial migration, severe ischial lysis. And next, please. Next slide. So this is again here bone graft applied, bone graft given, and then this non-cemented total hip. Yeah, that is the final. I think 7 years follow-up. She is. So yeah, Raju Bosho. Yeah, our good friend Raju Bosho can comment all this.
Let me first congratulate Professor Amjad for
man, come on, we are humble.
Taking us through some very complex cases which you did. Almost 15 cases you showed in 15 minutes, which is fantastic. One thing, there are two messages coming out of this
please,
presentation. One, that hemiarthroplasty using monopolar prosthesis like Thompson and Austin Moore should be condemned, especially in younger patients, because they tend to erode the acetabulum so fast, and they are sometimes quite challenging to revise, even to remove at the time of operation. So monopolar prosthesis should be avoided. Instead, a bipolar prosthesis should be used. Secondly, you have such large number of complex cases. Unfortunately, I don't see any publications coming out of Bangladesh, which is troubling me. And you have so many postgraduates, so many teachers.
Yes.
You people should start your own journal, and you should encourage your and support your younger generation to do research and publication. And I am ready to help. If you want, we can conduct a virtual research and publication webinar, and I can invite some of my editorial board members to give lectures, and this will generate some interest to your younger brigade.
Yes.
Really, sir. We need this at this moment.
Thank you.
Actually, I like to thank my friend Professor Amjad for his tremendous, very nice work. Actually, in rheumatoid arthritis, actually, I gone to so many literature actually, and they're telling actually everything. Everybody was in support of short-term outcome, but so far I actually seen actually his presentation, his follow-up was really long-term. It is praiseworthy. I feel proud of him. Really excellent.
Thank you, boy. Yeah.
Amjad sir, you please conclude the today's webinar. Congratulations, sir.
Yeah. Thank you, Dr. Fazlullah Kashem. You are doing a great job for our arthroplasty in Bangladesh. So we have started ABC, as you said. It's a beautiful name you have been given. Very much we are all thankful to you. And as our friend Raju Basho, you have invited him. He has joined kindly. We should take his full help in helping our subject. And I must congratulate our panelists, particularly Kayam Chaudhary, who has a tremendous, long-term experience, Dr. Sharathi Shom, and other panelists, Amir Hussain, and not the least is our speaker, Masood, who has done a lot of, he has presentation brilliantly. And I must say, it is a very difficult job. And as I said earlier, on the very beginning, on the very outset, that this is a topic which is so difficult, as Raju Basho has also said same. So this topic cannot be covered. And so many authors have so many ideas and so many things. And my small, humble, knowledge, I have gone through a little literatures, and I found that very difficult to, summarize and make it a simple one. So thank you, Dr. Masood. Thank you,
sir. Thank you, sir.
Thank you, everyone, Dr. Jahid, for joining.
Thank you, sir. Thank you,
So
sir.
this is the way we should go and do the arthroplasty in Bangladesh.
Sure, sir. Sure, inshallah.
Yes, sir.
Thank you, sir.
Thank you, sir. Thank you, sir.
Sir, thank you.
Assalamu alaikum.